everyone. I'm Cindy Grines from the Northside Hospital Cardiovascular Institute in Atlanta. And on behalf of the editor of JSCAI, Alexander Lansky, I'm proud to chair this conversation. And the conversation is going to be about this very interesting paper published in JSCAI. It's called Patient Characteristics and Outcomes of Radial to Femoral Site Crossover. This will be presented by Revathy Sampath-Kumar, who is a cardiology fellow at UCSD in San Diego. And panelists, a very esteemed group of panelists today. We have Ian Gilchrist from Pennsylvania. We have Michel Le May from the Ottawa Heart Institute and Pradyumna Tummala from Northside Hospital Cardiovascular Institute. Welcome, everyone.
Well, thanks for the opportunity to present this paper today. Very excited to be here on behalf of my co-authors to present our recent paper published in JSCAI titled Patient Characteristics and Outcomes of Radial to Femoral Access Site Crossover. Starting with a little bit of background, so optimal access site selection is critically important to ensure procedural success and minimize complications during percutaneous coronary interventions. Radial access has been associated with lower complications, mortality, and cost compared to femoral access, and is thus the recommended approach when technically feasible. The need for radial to femoral access site crossover remains a limitation of radial PCI, with an incidence of 3 to 10% reported in the literature, with unknown implications. There are limited prior studies on this topic with conflicting results. This variability underscores the need to elucidate the underlying mechanisms of radial to femoral crossover to develop strategies to minimize its occurrence, particularly in high-risk populations where radial to femoral crossover may have significant clinical implications. Thus, our objective was to assess the mechanism and rate of radial to femoral crossover and its impact on outcomes among a large contemporary cohort of patients who underwent PCI for any indication at a high-volume radial center. This is a retrospective cohort study design, and our outcomes included all-cause mortality up to 1 year post-PCI, ischemic MACE, which was defined as a composite of periprocedural MI and stroke, as well as bleeding complications. Our statistical analysis included Kaplan-Meier time-to-event analysis, multivariable Cox proportional hazards regression, as well as multivariable logistic regression models. We identified 3,496 patients who underwent PCI at UC San Diego Health from 2018 to 2022 for any indication. We excluded 435 patients that had prior CABG and 7 patients that had alternative access sites. And thus our final cohort was comprised of 3,054 patients. Of these patients, 2,287 patients had radial access, 109 patients required radial to femoral crossover, and 658 patients had femoral access. All of the radial access cases were right radial, and all of the femoral access cases were with ultrasound guidance. Looking at our results in terms of patient characteristics, you'll see here that the age of patients in the radial to femoral crossover group was higher than that of patients in the radial access group, but there were no differences in body mass index, sex, or past medical history between groups. Looking at procedural characteristics, in both the radial to femoral crossover and radial access group, there was roughly 14% of patients who presented with STEMI, 31% of patients who presented with NSTEMI, 35% of patients that presented with stable angina, and the majority of patients had non-left main one vessel disease. Patients who required radial to femoral crossover had longer fluoroscopy time and received more contrast volume compared to patients who had radial access. Among STEMI patients, those who required radial to femoral crossover had numerically longer door-to-reperfusion time, but this did not reach statistical significance. Patients who required radial to femoral crossover had longer admission duration compared to patients who had radial access. There was a 4.5% incidence of radial to femoral crossover among patients that had attempted radial access. Reasons for radial to femoral crossover are shown here. The most common reason was tortuosity in 31% of cases, followed by vasospasm in 22% of cases, failed radial puncture in 19% of cases, and inability to advance the wire or sheath in 16% of cases. Notably, Ultrasound-guided radial access was not used upfront in any of the radial to femoral crossover cases. Operators attempted ultrasound-guided radial access in 31.2% of the cases before ultimately switching to femoral access. Age over 70 years, vasopressor support at the time of PCI, and dialysis dependence were independent predictors of radial to femoral crossover. Looking at peri-procedural complications, patients who required radial to femoral crossover had higher rates of bleeding complications, BARC 3 or above bleeding, and need for blood products compared to patients who had radial access, but there was no difference in ischemic MACE. There was no difference in peri-procedural complications between the radial to femoral crossover and femoral access groups. Patients who had radial access had lower rates of all bleeding complications compared to patients who had femoral access, but there was no difference in ischemic MACE. Looking at all-cause mortality, radial to femoral crossover was associated with a higher 30-day mortality compared to radial access. And this remained true even after adjusting for baseline patient demographics and clinical presentation. Radial to femoral crossover had an adjusted hazard ratio of 3.4 for 30-day all-cause mortality compared to radial access. There was no difference in longer-term mortality post-PCI. There was no mortality difference between radial to femoral crossover and femoral access at any time point. Femoral access was associated with higher mortality at all time points compared to radial access. Patients who had bleeding complications, irrespective of their access site, had higher mortality at all time points. So in conclusion, radial to femoral crossover is an enduring procedural challenge that is associated with higher short-term mortality and bleeding complications compared to radial access, without added risk compared to femoral access. We found that age greater than 70 years, vasopressor support, and dialysis dependence were associated with radial to femoral crossover. Despite the routine use of ultrasound guidance for femoral access and closure devices, major bleeding complications and post-PCI mortality remain higher with femoral access compared to radial access. Patients at high risk for radial to femoral crossover may benefit from initial ultrasound-guided radial access to maximize chances of successful radial access. When right radial access fails, patient outcomes may be improved by crossover to left radial or alternative forearm access before femoral access in certain situations. Thank you.
Outstanding presentation. I really appreciate it. One thing that I thought interesting looking at the fine print in the paper is that the increase in bleeding complications were not always at the access site. And in fact, the majority were not at the access site. And I wonder whether that means that we're giving higher doses of anticoagulants during these procedures, or perhaps these patients are sicker up front, causing them to bleed. And maybe, Michael, could you comment on that?
Our study was the SAFARI trial, and the number of patients in the SAFARI trial was 2,292. This is a trial that looked at primary PCI, so just a STEMI population. And we found our primary outcome was we were looking for a mortality benefit because the previous trial called the Radial trial, which was about 7,000 patients, had randomized patients that were STEMIs and non-STEMIs, and that was a neutral trial, and that the primary outcome was no different between radial and femoral. But on subset analysis, they had found that the STEMI population had a 2% absolute mortality benefit in terms of doing the radial. So we were puzzled by that, and we designed the SAFARI trial in order to look at whether or not patients having a radial approach would benefit. And in our trial, we were not able to find a difference in mortality outcome between the two. We didn't find a difference in bleeding either, and we did not use ultrasound guidance as it was done in this particular study, but we used fluoroscopic guidance and amongst experienced operators. I have to say that when you start counting the number of bleeds, there were more bleeds from the femoral approach numerically than there were from the radial approach. And there were 5 retroperitoneal bleeds from the femoral approach and 0 for the radial. So I think that when you look at bleeding, I think that there is concern that the femoral, no matter how good you are at it, and I think that we've seen this in this nice observation study that's presented by Dr. Kumar, and it shows that in an observation study, even despite the use of ultrasound, that we are still at risk of getting bleeds from the femoral approach. Our crossover rate in Safari was 8%, like in Rifle it was 9%. In this study here, I understand it's 4.5%, and it was approximately 4% in Matrix. So I think the fellow here should be congratulated really for a nice paper. It's always nice to see the data that we see in observational study parallel the randomized trials. And I think that just to say, where are the randomized trials? Well, there's a patient level meta-analysis that was put together, that showed that the radial still had a mortality benefit over the femoral.
Mm-hmm. Right. Right. So Revathy, this took place during COVID. Do you collect data on whether the patients were COVID positive?
That's a great question. We did not collect that data for this paper, but it would certainly be interesting as that could, of course, impact the mortality.
Mm-hmm. So Prad, you're the ultimate operator, very skilled at large bore femoral access, very skilled at radial. What is your default approach? Do you routinely go for radial, and do you use ultrasound guidance for your radial?
So no, and Cindy, I was trained in the 1990s, and so started off as a femoral operator, and did some radial in training, but not as much. But then I adopted the radial technique over the years, and so by 2005 to 2007 or so, I was getting more majority radial, and now I'm about 90% radial and 10% femoral, basically, especially for STEMIs and acute coronary syndromes. And when people have bypass grafts, if they have bilateral memories, I go femoral and such. So, it's interesting, as far as technique and everything, volume and patient anatomy and patient characteristics and the operator's I guess experience all play a role in the overall outcome of the patient. And I think what I was struck by with your study, Revathy, is that you've had these patients who are not doing well, who crossed over, had vasospasm, or they had more vasopressor use, so they were in shock. They were older, and they were, had more dialysis patients as well. So the question is, how did you control for that in a multivariate, analysis? Did you compare basically the same patients, the same type of patients who had a radial approach to those who had the crossover, to those who had the femoral? Did you have enough numbers to even do that, actually? I have a question about that.
Yeah, so we actually did a multivariable regression to account for patient characteristics as well as ACS. So we included dialysis dependence in that model, along with age and a variety of other comorbidities, but we didn't have enough that crossed over to do like a propensity matched analysis, for example.
And I'm curious as far as the femoral volume, again, volume does seem to make a difference. Dr. Le May's, group did a lot of femorals actually. And so the Safari trial really was a bit of a wash. I mean, you guys had great outcomes with both femoral and radial. My group actually had 6 operators basically, and we looked at our STEMI cases between 2015 and 2018, 3 consecutive years. We had about almost 700 STEMIs basically, and half got radial and half got femoral. Now, these were not randomized. These were just a series. And we kind of avoided doing radials, even though we were radial enthusiasts. We avoided doing radials in those people who were shocky and those people, who had like 4 radial pulses. So typically we don't use ultrasound for radials, at least back then we didn't. And we didn't use femorals, ultrasound for femorals either back then, because we did literally thousands of cases, femorals before. Our TIMI major bleed rate was 0.8% in the femoral and 0.32 in our radial. and minor bleed rate was 5.59 in femoral and 2.22 in radial. So minor bleeds were higher with femoral. We had a 68% vascular closure percentage, so with periclosis. And our blood transfusion rate was exactly the same, actually 0.5 in the femoral and 0.96 in the radial. Mortality was about the same, 0.8% in femoral and 0.96 in the radial. So that was a series over 3 years between 2015 and 2018. Again, not huge numbers like Safari, but we had about 700 patients altogether. So I do think that maybe choosing femoral or whatever's easier for the patient and easier for the operator, and along with, the patient's clinical condition probably plays a role in overall outcomes. It's just my 2 cents in all this.
Well, thank you, Prad. And Ian, what is your thoughts on this? And what kind of patients would you start with the femoral approach?
Well, we basically use radial unless there is a clear indication to use the femoral artery. Primary indication to use the femoral artery would be large bore. The radial, we ultrasound all our vessels. So if you're going to get an IJ vein, you're going to do it with ultrasound. If you're getting a radial or ulnar or dorsal radial, it's ultrasound is put out there on the table to begin with, just like with the leg. We feel that the house staff all learned how to do ultrasound as residents. They come in as fellows, and they very quickly, get first stick access to just about any vessel. And we only have about a 1% crossover to the leg. And if you wait and use ultrasound after you've been poking for a while, you've lost all the advantage of the ultrasound because the artery has gotten spasmed up. In renal patients, often the arteries are calcified and you can't feel them well with your fingers. If you use ultrasound, they're right there. Likewise, patients in shock, use ultrasound, the vessel is right there. As noted in the Safari trial, you can't get a retroperitoneal hemorrhage from a radial stick. You can get one from the femoral stick no matter how good you are. So if it's appropriate to use radial, we go radial first or flip to the ulnar if the radial artery doesn't look good, or to the contralateral arm. But we know up front whether it's going to be okay or not because the ultrasound catheter is all set, ready to go for us, and no one's wasting time at the beginning of the case asking for someone to set up that. The other point I think this shows is that if you want to reduce your complications, just follow the bleeding. And anything you can do to reduce bleeding, I think, results in a better outcome. And I know there's been a lot of arguments on why, but it's just whether it's mechanical support or all these different procedures we can do, the more you bleed, the worse the outcome. So I think radial is just one more aspect, or forearm access, as I like to say, is just one more part of reducing bleeding. And that's part of what we need to look at is how can we best reduce bleeding. And
Right. Well, thank you, Ian. I'm with you. I use ultrasound guided access because I'm struck by how often these radial arteries roll or how tiny they are. And so having the ultrasound guidance has been very effective, at least in my hands. So any other comments on this great paper?
I think that it was a great paper, and I would like to ask Revathy how she would approach a patient now where she's thinking about changing to the femoral. Would she persist, and how would she deal with spasm and tortuosity? Would she go over to the left radial? What would be the recommendation knowing the data now?
Yeah, so I think the main thing that struck me based on our results is that none of the crossover cases had ultrasound use up front. And in our lab now, the practice has been to have the ultrasound probe prepped, sterile, ready to go at the start of the case. And I'm very much training in an era where most of our cases are ultrasound guided, whether it's femoral or radial. So I think what's going to strike me is use ultrasound. If you have ultrasound and it's set up and it's not a time constraint, use the ultrasound to define the anatomy and make sure you get a good stick. even on radial. And if that doesn't work, falling back to the usual techniques to try to, whether it's mitigating or navigating a radial loop attempt, adequate sedation, analgesia, etc. And then beyond that, if right radial fails, I would be more wanting to go for left radial. I'm not as comfortable with our alternative forearm access, but I would like to learn that as well. If you can avoid femoral, that would be great. But in certain cases, like we talked about shock, when it's a time-sensitive situation, of course, femoral access is necessary. So I think there's a role for all the axes, but definitely radial first.
You do use radial during shock for your coronary angiography. That leaves your legs wide open for any of the types of support devices you want. Now, granted, you can, with an impella, put your guide next to the impella through the sheath, but overall, you can basically have two operators working. If one is doing coronaries from the wrist, the other can be working on getting the support device up through the legs.
Yeah, good point.
They had a quick question about just, how do you mitigate the femoral access bleeding risk, in your institution? Do you typically have like a sheath pull team? Do you have do you use closure devices? What's the in general way that you approach it?
Yeah, we use closure devices when it's feasible anatomically, and we do it in non-heart transplant patients. But if we have to do manual closure, it's either done by the general cardiology fellow, interventional fellow, or we do have a sheath pull team in our PTUs as well.
Okay, outstanding. Okay, I think we all learned a lot. Even though we're much more facile in radial arteries, there are these cases that still aren't doable by radial. And so I think the good news is that even though you had a slight increase in complication rate with your crossover, there's no difference in the severe outcomes, right? So I think it's a reasonable thing to continue to try to do radial first and have a small number crossover. Okay, I want to thank everybody for joining us today. Bye, everybody.